I want to thank Liz and Pamela for the opportunity for me to be here today. For those of you that I have not had a chance to meet yet, I'm Tanisha Carino. I'm the Executive Director at FasterCures. For those of you that don't know FasterCures, we're a nonprofit and a Center of the Milken Institute. For the last 15 years, we've been dedicated to saving lives by saving time it takes to get science to all patients. And I just recently joined FasterCures in January, and about a month into it, Pamela called and said, why don't you come join us at MDIC? Previous to FasterCures, I'd spent a lot of my early career in the device world, but it had been quite some time since I'd really worked with the device industry, and I'm really pleased. I've been here all day today listening to the work that MDIC has done in terms of its focus on NEST, also its focus on regulatory science, and I think this panel in particular gives us an opportunity of taking a step back and processing through a lot of the trends that we heard today in terms of the importance of patient engagement, what does it mean to build transparency and trust, and how can we create a more predictable system in terms of the expectations that the industry will face in getting products not only approved, but actual access to patients, which is what we all care about today. As many of you all know, or that you saw earlier today, MDIC recently launched its Health Economics and Patient Access Initiative. And the focus of that initiative is really intended to increase the predictability of both public and private sector coverage decisions, and in turn to reduce the cost and risk associated with commercializing new technologies. I, for one, was blown away this morning at the FDA Commissioner's first announcement out of the gate, was really around the expansion of the 2016 private payer program and the building off of the FDA CMS Parallel Review Program that, as many of you all have known, have been in place for quite some time. If you read in that press release that came out today, I was actually very surprised to see there had been over 70 inquiries around FDA CMS Parallel Review. And one of the things I know Tamara is gonna talk about today is that it isn't just about the formal program that we really need to be focused on. It's around how do we create an environment of collaboration and the ability for all of us as stakeholders to work together among the industry, the regulator, the payers, but also patients in defining what really are the unmet needs. How do we design evidence to really get at the questions that all of us are anticipating that come with new technologies? And I also wanted to make sure that we spend some time to have a conversation today about what would we want MDIC to really focus on. This is a great opportunity. In launching this new program, we really are able to take a step back and say, what are the problems that the industry really faces? And how do we continue to build on the momentum that we have in the regulatory science and the new data infrastructure that are being created to really achieve this goal of predictability and access? So with that today, I have three amazing speakers. I am going to start with Jennifer. Jennifer has been involved with clinical research and regulatory affairs for more than 20 years and is currently the president of Cook Research Incorporated, which is involved in product development, testing, clinical studies, medical and scientific writing, and regulatory submissions. Jennifer also serves as the global functional leader for clinical affairs for the Cook organization. I've asked each of the speakers to do 1 or 2 minutes of introduction, and then we're going to open it up for a discussion, and then we're going to leave enough time for Q&A to the audience. Jennifer, why don't you begin for us?
Well, here we go. Start with the mic on. I am sure you're trying to figure out exactly how does clinical research, how does research fit into this conversation around health economics and patient access? Well, it actually starts with us. It starts with the idea of understanding what the patient's needs are, understanding what the physician is trying to treat, and then bringing that together to create that technology. And being able to look at that technology across the life cycle of the product. And when we start thinking about the economics of bringing a particular product to market, we start from the very beginning. So it could be 10 years before we would actually be able to commercialize a product, but we are trying to think about what's the impact on the patient, what's the impact from a reimbursement standpoint, and what is it going to take to sustain that product through its total life cycle.
Great, Jennifer. We're going to circle back on many of the themes that you've laid out today. This with me today is also Tamara Syrek-Jensen. Tamara and I did not have a chance to overlap in my older days at CAG, but it is delightful to have you with us today. As many of you guys know, the CAG is responsible for establishing the national coverage policies for Medicare. And in order to do that, provide timely access to technologies that improve beneficiary health. Tamara has been one of the chief architects of Medicare's coverage with evidence development policy, which conditions coverage on the collection of data through clinical trials and registries. She's also been spearheaded the relationship that CMS has had with FDA, with other agencies like AHRQ and NIH, and has been involved in shepherding the MedCAC relative to its focus on evidentiary requirements moving forward. So Tamara, why don't you give one or two statements in terms of your perspective of the opportunities that exist?
Thanks, Tanisha. I have to say, I don't think that was in my bio. She needs to write it. Because every time I get on a panel, I'm like, I have to rewrite that. That was good. So everyone has a recording. I'm going to copy that. I appreciate that. And actually, it was interesting. I haven't met Jennifer before, but what she said really resonates in what I do in the coverage group at Medicare. It really is, as you heard this morning, you have regulatory science where you need to get through the FDA, but it's really looking at your full product cycle and figuring out what is your end goal. So you have your research that you need to do and you want to get through the FDA, but that's not where you want to end it. So as you are thinking about the FDA, think about your payer at the same time. And what type of evidence do we need before you even get to the FDA? What type of evidence do you need for a payer so that they will cover your particular technology or your device? So I was really happy to hear what you had to say because that is really our goal, is to engage all of you earlier in the product cycle so that you know what it is that we're looking for, so that you can do that at the same time that you are designing your trial, your registry, as you're getting through the FDA as well.
Great. Thanks, Tamara. And then with us today is Robin Bostic. Robin is the Divisional Vice President of Global Health Economics and Reimbursement for Abbott. Prior to joining the device industry, Robin spent many years in the insurance side, so she knows actually the private sector insurance industry well. Robin has extensive firsthand experience working with CMS and private payers to create national and regional coverage policies and secure coding and reimbursement of new innovative technologies, and has also led global market access efforts. Robin, thank you for being with us.
Thank you. That's how you start a career. As I was a payer, and so I had that perspective. And someone said, "Why isn't this insurance company paying for my product?" And I was a claims manager, and I said, "Well, did you tell them about it?" They're like, "Well, no. The doctor prescribed it. They should get it." And that started a 30-year career in reimbursement. And where that's come from is, working with Tamara's group and seeing an evolution of not just the traditional review of technologies where you do FDA approval and then you get on the market, and then after that you're like, oh, reimbursement, we're being denied. We need to establish our coverage now. As Tamara indicated, that's too late. So now we have this lovely new process, considered kind of the informal review, where you can get your protocol reviewed by Medicare. They'll tell you exactly what they think about it. You go into that discussion with them. They either agree to pay or reimburse for the clinical trial or not, but you know early whether what you're doing is going to be beneficial to the Medicare population if you meet your endpoints. And the nice thing about the informal review is if you have already a product that's FDA approved, you could potentially move forward with an NCD earlier than a new indication. So there's some flexibility about the informal review process. You could actually shorten the time to patient access if you collaborate with CMS. I know everyone thinks parallel review is the answer to everything. We do have a product in parallel review. The thing that's nice about parallel review, if you have a new indication and a new NCD, parallel review at least assures you that by the time you're finished with FDA and CMS, you will know exactly what patients will have access to your technologies. So what I've seen in the past 30 years is really a change and an evolution. And I think a lot of it came from the collaboration with FDA and CMS and what you guys have done together so that industry can now be part of that collaboration. And we have these channels that we can go. The hard part is deciding what products need to go into what channel, and do you have the evidence early enough to support that approach?
Thank you, Robin. I want to circle back to Jennifer and this idea of timing, because I think that is something that you're hearing across all three of these speakers. And even though we're talking about pre-approval, we're talking about post-approval, in many ways what I'm hearing is that there needs to be a concerted plan. Now, it's been a while since I was a consultant to the device industry, but I do remember that there was a lot of hesitancy that companies have, particularly smaller companies, to really consider those payer evidence requirements further up. Jennifer, help us understand from your perspective, what's really needed in terms of creating that urgency and the awareness that an organization needs to really connect the dots between not just designing the clinical trials and the studies from a regulatory perspective, but really incorporating not just U.S. payers, but the global payer environment as well.
Gosh, I would say that it probably is only going to take one failure or a couple failures to take a product through the development cycle, be really pleased with the outcomes, and then move through that approval process, but yet you cannot gain reimbursement and coverage for that. So it's that, that opportunity to learn from others, to be comfortable coming out and saying, this is where it didn't work. This is where we failed in that process. But in the day and age that we are, and especially given global markets and the pressures that industry is going through in these global markets, the laundry list of things to consider is significant. So reimbursement has to be at the top of the list.
Right. Thanks, Jennifer. Robin, do you have a perspective on that?
You know, I look at it now as patient access. I don't like the term market access. I like patient access. And when you really think about how do you get patients access to innovative technologies, it kind of tells you you need to have the FDA, CMS, and also the physician clinical group involved in your entire strategy toward establishing patient access, which of course includes approval as well as reimbursement.
Yep. Earlier today, we had a really great panel of the patient voices, and we had a talk. We had several issues raised around the idea of patient preference, the idea that different patient subpopulations may have a different feeling of the risk-benefit trade-off, as well as a really great comment around the idea of facility criteria and where is your centers of excellence and the idea of access. When you think about what you heard today, what does that mean for you all as it relates to this idea of patient engagement, even not just on the traditional pre-market approval, but across the spectrum of evidence generation? Any of the three of you?
So, well, I think patients are, the reason that you have Medicare is for the Medicare beneficiaries. That's key. So anything that we do, it's always having the patient at the middle and at the heart of the decisions that we make. And so the patient perspective is always very important. So one of the things that we are working on is there's a lot of treatments out there, and it's really what is the right treatment at the right time for the right patient. And so it's trying to develop the right evidence develop the right evidence so you can have these patient tools to make these decisions. So I think really where some of our focus is shared decision making. Mm-hmm. I think we still need to have some of that baseline evidence to get into those tools, and so there's not a lot of them out there yet, but it's still having all of that out there. So there's that conversation. So that they have the options. And then from our perspective, it's trying to get those options out there, that the things that we'll pay for with the things that show the right evidence that we'll pay for, so there are all those options for patients.
Yeah. That's so important in regard to patients being informed of what their choices are. But I'm going to go rogue a little bit. So one of the things that I get frustrated with is the local coverage process, and the fact that, and it's personal for me, my mom lives in Hillsborough, Texas, and there's a technology, I won't say specifically, we'll stay general. Her particular local provider doesn't reimburse for it, so she can't have access to it. But she can go across state lines and get the same kind of technology, have access access to it across state lines. But you know what? She's 82 years old, and she doesn't want to drive 3 hours away to see a doctor she doesn't know. So how do you, from a local coverage perspective, how do we address that? And then centers of excellence is a whole nother category. Being in rural Texas, if I can just get her to a cardiologist, I'm thankful, because then she can actually get at least directed where she needs to go. So we can say all these great things about, well, you need to have these wonderful centers of excellence. And maybe someday we'd have that hub and spoke. That would be the ideal situation, so that those patients out in those rural settings really could have access to that kind of care. I mean, that's the hope.
Great.
I think to expand on that a little bit more, when we're talking about maybe some technologies that are working towards getting that coverage, we're probably taking that technology into institutions that are already centers of excellence. We're taking it into those epicenters, Cleveland clinics and the Mayo clinics and Methodists, but where what was really striking for me this morning was when the patient was talking about Appalachia. And over time, as more and more experiences come with that technology, it will start going out in those spokes. And hopefully that's where we can take the idea around real world evidence and say, you know what, we're learning more about the benefit of this device. The risks are going down because we're getting more and more data. We're understanding those signals. And so thinking of taking a novel technology, what may have been initially novel, is now becoming a standard procedure. It's coronary stents. We would have never thought 20 years ago on coronary stents where we would be today, and where patients are being treated, and it's outpatient. They're not in an OR.
Yep. I reflect on some of the conversation that we're having about this idea of patient access, the tapestry of coverage decisions that may exist that patients have to navigate. Tamara, I don't know whether you'd be willing to talk about this, but how do we create awareness? Even if there's not an NCD, how do you create the predictability and the awareness in the local coverage environment for the technologies that may be coming to market? And what does that dynamic currently look like, or how could it look in the future?
I think that's a hard question to talk about with LCDs and how the different contractor medical directors in their local jurisdiction knows what's coming through the pike. And they have limited statutory authority. And so, when you're talking about a brand new, innovative device, and you have FDA approval, we really need to take a look at what was the information that got FDA approval. So the things you need to take under consideration: are there Medicare bennies in there? If there aren't any Medicare bennies, which have unique attributes, can we generalize that to the Medicare population for us to even make a decision on a coverage determination? And so there's that, how big was the trial where we can make these types of decisions. And so our contractors, they really can only make a yes or a no decision. And that's a hard place to be in a binary yes or no. So with a lot of these new innovative devices, I almost think that perhaps the national route it's a business decision, might be a better way, because now we have a middle ground. Right. And so you can do coverage with evidence development, where you are paying for these devices in the context of a clinical study, where you can maybe pull in real world data to figure out, okay, how does this work in the Medicare population? What are the long-term outcomes? These questions that probably Medicare has about these devices, where our contractors do not have that authority. And so it's hard to say, what is their predictability? Their statutory authority is the exact same statutory authority I have to write national coverage determination. Right. So really the answer we have, it's enough evidence that we have enough confidence that particular device will improve the health outcomes for our Medicare population. And depending on the device and the outcomes, when you come in to visit us, it's really, what is the problem that you're trying to solve? Right. And do you have enough evidence to demonstrate that you're solving that problem at the most basic level? So I don't know if guidance documents are going to help contractors. I think guidance documents, the agency has a statutory authority to do them. And so it's just now trying to figure out how do you get those done, and I think, and then, is it in disease state?
Yeah.
What is it? What is
So,
it?
for the audience that may not remember this, so since 2003, with the Medicare Modernization Act, CMS received the authority to create and promulgate coverage guidance documents, fashioned after what the FDA does. There are 3 standing coverage documents that exist today. They're not therapeutic specific, but I was going to ask Tamara the question of, when you think about the idea of predictability, there's the ability of individual companies to do the legwork, to sit down with each of the agencies to create, those types of one-to-one conversations. And then there's the route of creating blanket guidance documents or policies or signals that it doesn't take an individual company decision, and it can create a marketplace of people who understand what the necessary criteria or evidence can be. From your perspective, what do you think can be the most efficient path forward? What's likely?
For guidance, so specifically for guidance?
It doesn't have to be guidance. It could be, whether it's more one-on-one meetings that we're looking to encourage. The FDA's announcement of that program is really a one-to-one program. It's a company coming in, meeting particularly with, 10 payers now, private payers. That's still on the onus of the company to decide that that's
Right.
what they want to do, versus creating predictability the way the FDA does through guidance documents, or through even the MedCAC as an example could be a tool in creating that level of
Right.
predictability.
So it's certainly, so guidance documents are certainly something that is on our radar screen. And the reason that we did the heart failure MedCAC, I think it was almost 2 years ago, is to try to create this predictability in that space. The thought process, the questions we have is, okay, we can do one in heart failure, what's next? How do you do guidance documents? How do you divide them up? And so these are some of the conversations that I know many have been having. But that was our first step in that direction, in trying to create some predictability in that space, and what are the right outcomes we would take a look at if you were coming to us for a coverage determination. And one of my goals is to try to model that more and more in different spaces. I don't have anything on the horizon that we've announced on the horizon right now. So what is the next one that we might do? So that was an easy way to get to the heart failure space. While we didn't actually get the guidance document out, but at least we have that part in at least in the public space. But I will say, we have been running some data, at least internally. So what I have noticed as we took a look at a lot of the manufacturers or sponsors, I guess in FDA speak, when they have engaged CMS as they are going through the FDA process, their time from FDA approval to CMS coverage is significantly reduced. So I think that data is pretty convincing, that when you start engaging the payer earlier in your product cycle, you are more successful. It appears that you are more successful based on preliminary things that we're looking at. It's just timeline to getting CMS coverage. Just one other quick point. Remember, national coverage determinations, where you have a coverage determination by Medicare that applies across the nation, is only one of many pathways that you can take. So you do have the local pathway, and then you have, many things just go through a claim by claim adjudication. So as you are thinking about how you want to get your product not only to the market but to the patient, and the payer, an insurance company pays for it, you need to think about what is the right pathway to take for your particular product. So that is where you want to engage the payer earlier when they go to the FDA. So we can also talk about there are different pathways for you: informal parallel review, investigational device exemptions, coverage with evidence development, local coverage determination, or claim by claim adjudication. That's just Medicare. If your patients are in private payers, they probably have different pathways. I probably took way too much of my time, but
no. Jennifer and Robin, would you I would love for you to reflect on the question of what's I think that continuing to have this one-to-one collaboration company to payers is important. I think we were all encouraged by the availability to try to harmonize that on the FDA side and CMS's willingness to meet. Would love your perspective on what are other types of tools that create an environment of predictability.
Well, I think the new process in regard to PMA clinical trials, whether Category B and A, going through CMS, gives you that opportunity, there's this formal submission you make on certain clinical trials where they review it, and in that review, you can get a lot of good feedback from that protocol so that you're in alignment with CMS without having to even go through a informal review or a formal parallel review, because they'll give you a lot of feedback and they'll meet with you at that point in time, regardless of the path. Even if you think you may go local, ultimately they'll meet with you, where the local coverage people won't meet with you. The medical directors at the local plans don't meet with people much. They have these open hearings. They're very limited as to what you can say. So if you're wanting dialogue,
right,
and a way of really trying to figure out how's best to access the Medicare population during that clinical protocol development is key.
Jennifer?
I think what I would add to that is that continuous engagement. When you think about an IDE PMA route product, you're talking about something that could be in clinicals for 7 to 10 years. From the time you gain your IDE approval, you move through enrollment, you move through primary endpoint, all the way through the last follow-up. And so care changes in that process. More products may be coming onto the market, or more information is being learned in other regions of the world. And so being able to keep going back and touching base on, this is what we're seeing as far as standard of care. This is what is starting to change. We're no longer using this imaging, we're doing this imaging. And so making sure that all your stakeholders are aware of that change, because where we started and where we end up may be very different, and we need to be together in that collaboration, and in the end, the goal is to get that product to the patient.
Great. I know I see some people who may want to ask questions. I want to pause at this point and see if there are any questions from the audience before I go through mine. I think we have one here.
Thank you so much for your time this afternoon. It's not every day I get to talk to anybody from CMS. But as you know, my disease state and CMS have got a lot in common these days, considering we're the only disease where if you don't use your machine for a certain amount of hours, somebody actually comes and takes that machine out of your house. Whereas if you had diabetes or hypertension, if you weren't being adherent to your medicine, they actually come and want to know why you're not using it and bring you that education. So we understand as patients why CMS has made this ruling, because of what has gone on with the durable medical equipment companies.
Sorry, Adam, I had to make sure she knew which organization you were representing.
Yeah, I'm not with the doctors or the manufacturers. I'm with the patients who are literally dying because machines are being pulled out of their homes, whether they use it or not, in plain English. And that's the reason we assume that this has happened, is because the durable medical equipment and the sleep professionals have taken advantage of CMS, and anybody who walked in that was basically had a test was then given a machine. And we understand that, but it's been to a detriment of our patients. And what I mean by that is if patients aren't adherent, we have to give them the support, the education, the knowledge, especially if we want them in long-term clinical trials and looking at innovation or anything else. But when the exact system that's set up right now prevents us from getting them the care, that's a problem. So it's just more of a comment than anything. I didn't mean to put you on the spot, but you guys are talking about it, so I had to ask.
So thank you. I'm not sure. So I will say I'm not I'm not sure the whole equipment thing is in the coverage group, and I'm not entirely sure what that is. It sounds like a payment rule of some sort. So happy, but thank you for the comment. If you want to give me more information, happy to pass it along to my colleagues. You may be, if you're not talking to them, that does concern me, because we are a public agency and we work for all of you. So you do need, so please, at least in my world, it's an open door. And I say this a lot, I don't think I've ever turned down a meeting unless we're meeting for the 5th time on the exact same thing. And we've told you the same thing 5 times.
Tamara, I want to pick up on a little bit of the thread of that, which is, at least I think that the coverage group has made it very clear that they're willing to sit down and talk to manufacturers, sponsors early and often, and be iterative. Within the agency, and I know that where we're focused on MDIC is not just on coverage, it's really the whole suite of coverage coding payment, the broader reimbursement environment. Is there any move towards having some more coordination even within the agency so that everyone's learning? The point that I think Jennifer's making is a good one. Everybody's being brought along to what these technologies are, what's going to be needed in terms of coverage coding and payment.
So I will say I work very closely with my payment and my coding colleagues. And just to be clear, because I'm not sure what the knowledge is in the room, I work in Part A, Part B of Medicare, which is your traditional fee-for-service Medicare, and then it's in our national coverage determination, so then binding on our Medicare Advantage programs, which is Part C. But the key for anything you do in physician fee is you need 3 things, which is coverage, coding, and payment. And I always say it's like a 3-legged stool. If you don't have one of them, you don't have any of them. So you need all 3 for them to work. So I will say, at least for my group, we work very closely with our coding and our payment folks. And I don't want to speak on their behalf, but there are a lot of statutes and regulations and payment. And so a lot of that is what they need to work through. But we try to work through all those issues so that it's as efficient as we can through the particular regulations that we have. I know that the administrator is certainly very interested in trying to create efficiencies where we can. So those are some things that we are constantly trying to work through now, and that is something that she is really trying to work on, which is efficiencies and then reducing burden as well.
Thanks for that. I think we have another question in the audience.
Hi there, Anna McAllister-Slip, and I'm here primarily as a type 1 diabetes patient. But as a multi-layered policy nerd, I'm frequently asked questions about how do you interact with CMS and other payers as well, not just CMS. CMS, unlike FDA, other aspects of HHS, NIH, is the most opaque, difficult to understand organization within the health world, and I understand why in some respects, but I think it's that way, and it feels at least that it's that way by design. And one of the things that bothers me about all of these conversations, and I don't mean it directed towards this panel, is that all of the discussions happen between CMS and the manufacturer, and it seems like all the decisions are made in that sort of slightly antagonistic, not quite antagonistic, that's overstating it, relationship. But I'd like to know what CMS is actually doing, or other payers are actually doing to encourage and actively seek out dialogue with patients about coming up with mechanisms for deciding which device is best or drug is best for this type of person or patient, and how can we create policies around reimbursement that is done with the nuances of individual, cases in mind, or smaller sub-cohorts in mind, as opposed to one-size-fits-all decision. Because my understanding is that manufacturers have no incentive to get what's best for the patient. Their incentive is to get access to their device or drug, and if it's done at the cost of other devices or drugs, even better. I mean, that's, the way it tends to. to fold out.
Yeah, let me address that first, and thank you for that comment. I appreciate that perspective, because it's true. I think oftentimes the patient feels like they're not really what's being considered through all the policy reviews. There's a couple of things. As a manufacturer of a technology, I need my patients to live well, because then I do well. It's just that simple. I do have an agenda very much aligned with the patients. I want a very specific patient population to thrive, is what I'm wanting. There are mechanisms within each payer system for the patient to have a voice today. There's an appeal process through the commercial payers where I can just tell you 3 times. You have to appeal 3 times until you get an outside medical director to review it. And I'd say about 75% of the time, you'll win that one, but it takes a long time. A lot of patients can't wait that long.
Oh, I've done it many times.
But here's the other question. A lot of patients aren't as educated as you are. And so they just say, no.
Give up.
Yeah,
Right.
they give up. And like, I think of my mom again. I have to help her navigate through this. You know, with CMS, they also have an appeal process that you can go through, which is, if your technology's been studied and there isn't a national coverage decision that says no, you have a very good avenue to appeal that as well. How do you educate the patients about these methods today? Physicians don't want to get so involved, they get tired. So, I mean, maybe the NIH, I know they're doing some things. I know that as a manufacturer, we have patients on all of our R&D projects, you know, to make sure that what we're creating is something that patients want. I know globally we're doing patient satisfaction in other countries. Patient preference and voice is being heard more loudly, I think, than even in the United States. The United States is a little bit behind, but I'm starting to see meetings like this. I've met this lady before too in a couple of these meetings, and your voice is being heard, and it is making a difference in DC, because I've heard it a couple of times myself.
So for CMS, I definitely think the patient's voice is very important. And we have just had 2 of our advisory committees give us advice on the confidence of the evidence for example, for CAR-T. And so we, not only do we have a patient advocate, but we also invite patients to that advisory committee. And we had, I think what he told me, he was the 2nd patient in the CAR-T trial. So we definitely try to get that patient voice, at least in our advisory committees, and it's an open meeting, so we invite patients to also come to those meetings and speak. I also have also tried to reach out to a lot of the patient advocacy groups, because one of the things we do is when we, and actually I think I reached out to Tanisha. I think I owe you a call. Now that I think about it.
Not that we're a patient advocacy group, but we do make connections when we can.
Because one of the things that I've been trying to work on for a long time, and I'm hopefully I'll get successful in the near future, is we reach out to patients. We have a public notice process to try to recruit our public panel members. And so some of them are experts in certain areas like academics, cardiology, you name it. But we also have a patient advocate on that panel. And what I'm trying to get to is out to more of these patient advocacy groups or these patients to try to recruit them to be part of this panel. And the challenge that I'm faced is, what is the right criteria? Do I think, for example, for a lot of the experts on this panel, they've published a lot of publications. They're very known in that particular field. But what is the criteria for a patient? Because their role on that panel may be different, which is their experience. What is important to them versus, well, the methodology of this clinical trial isn't really great because. And so it's really trying to work with them so that I understand, because I don't know what it is, and maybe it is the same as the rest of the panel, what is that right criteria? So that when we go out with that next public notice, that I can get more applicants to come in, and so that I can get those patients on these right panels. I thought the CAR-T panel did a really nice job of getting some of these patients on the panel to hear their perspective, because that perspective was really key as we were talking that day.
And I just also want to just I don't want Tamara to sell CAG too short, too. One of the biggest distinctions between a Medicare coverage policy, particularly at NCD, and for those of you that have not read in detail on NCD, and the private payer coverage decisions is Medicare does spend an exhaustive amount of time going through detail by detail the studies that it had considered, what it thought about the different comparator arms, a lot of rationale for where their coverage determination is actually landing. And that really speaks to me about the last panel that we heard, is this notion of transparency. Because I appreciate that companies can come in and meet. I think that's great. The device sector is made up of really, really small companies by and large, and they just may not have the bandwidth to spend the time and resources meeting with every payer that they need to meet with. And so the more that we have the transparency and the predictability out there, I feel like that is what is really going to be needed to raise all boats and really get to the predictability that we all want in terms of the patient access. So I'm being signaled that we're out of time. Thank you to this panel for being part of our discussion today, and thank you all for your questions.